Hello, welcome to Chris Privy on day 2. Today is 19th October and we are in Mumbai. And I'm your host for Chris Privy, Dr. Abad Khan. I'm an interventional cardiologist practicing in Ghaziabad. With me right now, I have an international faculty member, Dr. Antonis Pentazas. Spell that correctly?
Yeah.
He is a consultant cardiologist based at Hayfield Hospital, UK, and the group's clinical lead for cardiomyopathy. Dr. Pentazis is actively involved in research on left ventricular outflow tract obstruction, non-compaction cardiomyopathy, and ARVC. He's also contributed to the guidelines on Friedreich's ataxia for ataxia in UK. Welcome, Dr. Antonis. Yes?
Can we, the last thing is a long time ago. Maybe it would be more interesting for you to say that I was the previous chairman of the European Society of Cardiology Working Group.
Oh, he was also the previous chairman of the Society for the Cardiology Working Group. Yeah, absolutely. So, coming to the few questions we'd like to hear from you, few answers also, if we can. The prevalence of hypertrophic obstructive cardiomyopathy has been rising mainly due to the one of the reasons is maybe due to better imaging and surveillance, as well as the aging and the population at risk, the left ventricular outflow tract obstruction also. However, for many years, no drug has really shown to improve in hard clinical endpoints such as reducing death rates until the latest entry of cardiac myosin inhibitors. Why is that the case compared to other cardiomyopathies, dilated cardiomyopathies for that matter? What makes hypertrophic cardiomyopathy so difficult to treat?
Thank you for your question. That's a very interesting question. Starting from the prevalence of hypertrophic cardiomyopathy, it has gone up for a number of reasons. One of them is the awareness, the increased awareness among the cardiology society. So people think about it more frequently and they diagnose it more frequently. Also because of the better imaging, as you said, because the resolution on cardiac imaging nowadays is far better than what it used to be 10 or 20 years ago. But it's also the fact that we can genetically test these patients and we can identify early the so-called incomplete phenotypes. So those clinical presentations which otherwise would not reach the diagnostic threshold, but now that we know that they have a predisposition to develop hypertrophic cardiomyopathy, we monitor them, we see them in the families of the people who are diagnosed first, and we reach an early diagnosis in them as well. This is very important, really, because sometimes in medicine, if not most of the times, the earlier we intervene, the better. Yes. As for the prognosis of this condition, there has been a lot of focus, and rightly so, in the last years, in the last many years, on the prevention of sudden death. Sudden death is a very dramatic complication of hypertrophic cardiomyopathy, and of course we have always wanted, and we still want, to predict who is at risk of sudden death and prevent it by advising them how to live better and implanting defibrillators. So we have the right things to do for these patients to prevent the risk of sudden death. However, in the overall population, in the larger population with patients with hypertrophic cardiomyopathy, the main issue has not been the sudden death because it is tragic but rare, fortunately rare. The main issue has been the symptoms that the patients have been experiencing, and we have not focused very much on that for two reasons. One is probably because the risk of sudden death has overshadowed the patient's symptoms and the quality of the patient's lives, which was deteriorating over the time. And the second is because we didn't really have any treatment to give them if we identified that they're very symptomatic. So the treatments available for hypertrophic cardiomyopathy were very basic, essentially not developed or designed for this disease, but for other diseases where they work very well. But in hypertrophic cardiomyopathy and obstructive hypertrophic cardiomyopathy, probably they haven't done the trick for many years. So that has resulted in sort of reduced interest in identifying the symptomatic status of these patients, and therefore we have not been aware of this large number of patients who suffer daily symptoms. And therefore, we are now in front of a great development, and I think we'll have opportunities to discuss it.
Yes, absolutely. Now the as you rightly said, now with the introduction of a pathology-specific medications for cardiomyopathy, for hypertrophic cardiomyopathy, how do you see that this impacting the natural history of disease?
With the new medication, you mean?
Yeah, with the new medication for the pathology-specific medications coming up, how do you see that it will change the natural history of disease?
It will first change the symptomatic status of these patients. And as I said, it gives us the opportunity to dig deeper into the symptoms they experience, because typically patients with hypertrophic cardiomyopathy have adjusted to their symptoms, and over the years they have reduced physical activity to avoid symptoms, so we probably underestimate the level of the symptoms. Therefore, we will first be treating symptoms as we used to with the previous medical options, beta blockers, calcium antagonists, and so on. As for the prognosis, we are very, impatient as a group, cardiologists. We want to see immediately a change of the prognosis. I hope it will be there. The way these new drugs work is at the level of the protein. They also improve the metabolism of the sarcomere. So hopefully they will have a great impact in the future on the patient's natural history and prognosis. But the truth is that we don't have this data yet. So the data needs to be populated with larger numbers, with years of treatment, before we can say that they actually not just treat the symptoms, these new drugs, the myosin inhibitors, but they also improve the prognosis of these patients.
So he says that not only we have to be patient, that is the most important part being a cardiologist, we are impatient people. He also says that data is still limited and we should wait. Waiting is perhaps, and getting data is perhaps the best option, he says. Now, on the contrary, with the rapid advancement in the usage and safety of interventional electrosurgery for hypertrophic cardiomyopathy with left ventricular outflow obstruction, such as the procedures demonstrated and almost now pioneered by Dr. Jafar Khan in St. Francis Institute, US. What's your take on that? Was the rise of interventional electrosurgery, like the procedures like SISAM, for HOCM patients or hypertrophic cardiomyopathy patients, they can pose a challenge to the medical therapy and create a situation of David versus Goliath scenario?
It's not a competition. I think that over the years, lacking very good medical options, good interventional invasive options have been developed, with surgical myectomy being performed in great numbers in the United States, with alcohol ablations performed in a number of places around the world. The issue with these procedures, and you named a number of colleagues, is that they are very successfully and safely performed by people who have great experience. So what will happen in the rest of the world? What was happening in the rest of the world is that they were not accessible.
Absolutely.
So that posed a big challenge. So how to make these treatment management options available to a large number of patients. And now that we have a medical option which probably and most definitely does the trick, it will not come up as a competitor to those procedures, because they will still have a role. There will still be patients who are eligible, and it will be in their best interest to have those procedures. But there will also be patients who will improve from the medical treatment, which has always been the first line treatment. So before patients were referred for invasive options, they have always been tried on all medical options. And the same concept applies here. Patients will be tried on all medical options, and if they improve, that's great. They don't need to refer on. If they don't, they will be referred on. So there will be a good role for the invasive procedures as well. The other point I wanted to make is that all these procedures, although, as I said, very successful in good hands, they have not changed the natural history of this condition, because the underlying condition remains the same. We may take the obstruction away from a heart by removing 10 grams from the left ventricular outflow tract, but the rest of the heart is exactly the same. So if we have the option to treat the whole heart, the sarcomeres, to improve the metabolism of the heart, we actually have a much more holistic approach rather than just eliminate the obstruction from the left ventricular outflow tract.
Perfect. So two things absolutely clear. no two strategies are competing against each other. They are both holistically and amplifying the treatment for this kind of subset of patients, that is the hypertrophic obstructive cardiomyopathy patients. And second thing is, as Dr. Antonis wants to say that treating the disease as holistically on the pathology itself may work better in the future. And sir, what is your work currently you are doing on hypertrophic cardiomyopathy, and what is the future you think is likely to be for these patients?
We have a very holistic approach to the management of these patients. So we try to get to the earliest possible diagnosis. It's key to diagnose these patients early. Then we try to deep phenotype them, which means to get all the details of the phenotype, the anatomical details, but also functional details and details which are dynamic, because in this particular condition there are a lot of changes when the heart beats faster during exercise, and we need to capture all this. Some patients do not appear to be obstructive at rest, for example, but they are obstructive on provocation. So we provoke all this, we are a bit provocative, and we try to get to the bottom of the patient's symptoms to understand the mechanisms. And then the patients are followed by a multidisciplinary team, which involves cardiac electrophysiologists, obviously us experts in hypertrophic cardiomyopathy, colleagues with experience in heart failure, and many other colleagues, imaging colleagues who can contribute to their patients' care, and also by a team of nurses who look after their patients for the symptoms, titrate the right doses of the medication, and so on. As the patient goes through this journey and this pathway, of course, we also look at the family, we do genetic testing, and with all this information, at some point, we may decide that something else is required. However, nowadays, it's part of our routine and standard practice to give the patients the option of a myosin inhibitor of the mavacamten, because it is available, and with the appropriate monitoring, it's a safe and very successful type of treatment. So we give them this option as per the international guidelines soon after we start their treatment, and not wait too long until the patients deteriorate and they need an intervention or an invasive option. And I believe that the future is in this direction. So we'll be treating these patients in a much more successful way than what we used to. Possibly, coming back to your earlier question, if we think that there is a good impact on prognosis, we may consider treating the patients earlier and not wait until they become very symptomatic. And possibly one day we will also be looking at the genetic causes of this condition and to use them in the therapy, in the treatment of the patient.
Perfect answer. And as Dr. Antonis wants to emphasize, and he has repeatedly emphasized in all his answers, that holistic approach is the way to go in most of the conditions, especially in hypertrophic cardiomyopathy. The electrophysiologist has a role to play, the experts in HOCM has a role to play, the nurses has a role to play, and through this journey for the patients, everybody has a significant role to play. Thank you, Dr. Antonis.
One last comment, actually,
absolutely,
just to emphasize the great importance of the early diagnosis. I said that earlier, but it's actually key, is of paramount importance to think of this condition early, especially in young people, because sometimes we don't think of cardiac conditions in young people.
Yes.
To think of this condition, investigate it, diagnose it, and then everything with the whole team and the holistic approach will probably go in the right direction. Thank you so much.
Perfectly put, and thank you so much, and we'll be seeing you for the talk.
My pleasure. Thank you.
Thank you. Okay.
Huh?
Yeah.